Hello, this is Robert Lee. This is a brief video on radiotherapy following prostatectomy. We're calling it the Potpourri version, in that we address a whole bunch of different topics. So we'll look at total dose, we'll look at hypofractionation, the role of elective nodal radiotherapy, and in a slight diversion, we'll look at future trials that are either ongoing or will be soon. First, to the question of radiation dose. Lots of retrospective data, sort of all over the map. We have two randomized trials that we'll address first. This is the Chinese randomized trial, detectable PSA. It's very small, only 144 patients. The sample size was generated with the hypothesis that the increase in dose from 72 to 66 will increase the biochemical relapse-free survival by 20%. Here are the results published just this year with a median follow-up of 48 months. P-values, as you see there, there's about a 6 to 7% absolute difference at 4 years. Whether that's clinically meaningful or not, it's hard to know. And with a small study like this, you're never going to get a p-value associated with that. They looked at GU toxicity as well and didn't really see any difference. So efficacy didn't seem to be any different, but toxicity didn't seem to be any different. But again, this is a very small study. We have another study, the Swiss randomized trial, similar, slightly different doses. Low dose is 64, high dose is 70 gray. A little bit larger, 350 patients. No efficacy has been reported on this trial yet. Incontinence and quality of life has been reported. The bottom line is there doesn't seem to be any difference in the risk of urinary incontinence according to dose, and patient-reported quality of life is similar, although it doesn't show the quality of life data. Hypofractionation, just like in definitive radiotherapy, people are beginning to wonder whether we can go quicker. There is a completed but yet to be reported study, Energy GU003. This is Mark Bujanowski's study. 300 men, a quality of life endpoint comparing 66 at 1.8 to 65 at 2.5. I expect the results over the summer, and we may in fact see this at ASTRO 2020. Elective nodal radiation, a question we keep asking in multiple different contexts. RTOG 0534 is salvage radiation, basically 3-arm study, prostate bed alone, prostate bed plus short-term ADT, prostate pelvis plus short-term ADT. Has been reported at ASTRO 2018, has not been published. Here's the interim analysis that was recommended by the Data Monitoring Committee. Basically using freedom from progression, arm 3 was better than 2 was better than 1. Now, I'm skeptical of the freedom from progression endpoint when some of the arms have hormonal therapy and the others don't. I'd be much more keen to see more clinically relevant endpoints like distant metastasis or survival. They did report distant metastasis, and basically it seems like there may be a little bump from hormonal therapy compared to no hormonal therapy. So 3 versus 1, 2 versus 1 seemed to be a benefit. Still relatively early, and we know from JETIG 16 that there may be an effect on distant metastasis with short-term ADT, but I think the question of pelvic treatment is still to be determined. So here are the randomized trials of dose. All of the other information that I've showed to you has yet to be published. Change things up a little bit. This is the portfolio of postoperative prostate cancer studies within the NRG. The first 3 studies are presently open, and you can see their accrual status. The node positive study is approved and will be opening soon, and then the oligometastatic study is yet to be approved. Hopefully it will be open maybe within a year. I won't address the oligometastatic study in this video, but we'll discuss it in the video devoted to oligometastatic disease. So GU006 essentially is looking at, rather than conventional GnRH, looking at a new anti-androgen, apalutamide versus placebo. So this is somewhat analogous to 9601, but the duration of treatment is only 6 months instead of 24 months, and this is looking at really a lower risk group of people. So everyone gets radiation plus or minus apalutamide. This is the STEEL study, which is looking at a higher risk group of patients, PSA above 0.7. Standard arm is salvage radiotherapy plus 2 years of GnRH, and the experimental arm adds enzalutamide to that regimen. GU002 is for those particularly bad actors with a detectable PSA immediately after surgery, so that their PSA nadir never gets below 0.2. This is a very bad group of patients. The risk of distant metastasis with treatment, conventional treatment, approaches 25% at 5 years. This is basically addressing the role of adjuvant docetaxel. So everyone gets radiation and 6 months of hormones. The randomization is plus minus adjuvant docetaxel. This is Ron Chen's study, which should be opening soon. Basically, it incorporates Axumin scans and looks at pathologic node positive patients. The standard arm is radiotherapy plus 2 years of GnRH agonists, and the experimental arm adds abiraterone and apalutamide to the 2 years of ADT.